Hello and good afternoon, good evening to everyone who's attending with us today from across Canada. We're so happy to have you here with us for our next iteration of our national educational webinar with Ostomy Canada Society. My name's Troy. I'm one of our board members here with Ostomy Canada, and I'm joined by Raizman today, who's going to be our guest speaker. Before I get into our topic today and into introducing Rose, just a quick little housekeeping items. Firstly, we're going to have a Q&A portion at the end of this. I know that quite a few people have already submitted some fantastic questions that Rose has mostly included into her presentation. But if you do have questions that we don't answer throughout this presentation, please feel free to use that Q&A. It's a little toolbar item there. If you ask your questions in that toolbar, we'll be able to see them on our end and try to get to as many as we can before we end today. We're also going to be able to make use of our chat feature as well behind the scenes here, but again, Q&A will be the best way to answer those. This webinar is being recorded, so we will have this available after the fact if you want to go review some of this, or if a colleague, a friend, a family member wants to go watch this after the fact, you're welcome to do so, and that will exist archived on our website at ostomycanada.ca. The other thing I just wanted to quickly mention is that this is one of 4 that we typically try to host each year. We're going to have a survey that will go out to you later on after this webinar. So if you have some particular topics or ideas that you want to suggest to us to have in the future, we'll definitely welcome those. So stay tuned in your email inbox for that. So without further ado, I'm very, very excited to be introducing our guest speaker for our presentation today on hernias and prolapses. Do you have one, and how you can act on it? And I'm joined today by Rose Raizman, who is from Toronto, Ontario, and has an illustrious nursing career spanning over 2 decades across diverse roles. Her journey encompasses positions as a staff nurse, educator, supervisor, faculty member, researcher, special project coordinator, and clinical nurse specialist, both in Canada and in Israel as well. With a fervent commitment to holistic wellness, Rose has pursued certifications in personal health, 360 degrees training, Genesis psychotherapy, functional nutrition, and life coaching. And her role as a wound care nurse practitioner at Scarborough Health Network, a prominent community hospital in Toronto, is a testament to her dedication to facilitating individuals in achieving and sustaining optimal health. Rose extends her expertise beyond clinical practice by engaging in mentorship and education, serving as an adjunct lecturer at the Lawrence S. Bloomberg Faculty of Nursing at the University of Toronto. Proficient in 3 languages, she has contributed significantly to the field through extensive research endeavors, emerging as a national and international speaker on various ostomy and wound-related subjects. And additionally, her work has been published, further solidifying her influence in the nursing community. So I'm very, very excited and happy to have Rose join us today. And Rose, I will pass over the presentation to you. Thank you so much. And I'll just, if you can just unmute yourself as well there. Sorry about that.
Hello, and thank you for having me. And I hope that our seminar today will answer some of your questions and guide you further. So we're going to talk today about ostomy, hernias, and prolapses. And if you have one, how to act on it. And I'm more than happy if you'll have questions. And all the questions which I got, I try to answer in this presentation. So today we'll look at the causes of hernia and prolapses. And a lot of people was asking how I can prevent prolapse. So hopefully you'll get the answer. How do they look? And if you can determine if you have one or not, or you need a professional opinion on it, and some practical management and prevention strategies for those conditions. So you all have ostomy. So it's just a quick reminder that of the anatomy, and that the ostomy, it's a piece of bowel who comes through the abdomen. So when you're looking, there is a lot of bowel behind the abdominal wall. This is abdominal wall. And there is a layer of the skin, subcutaneous fat, and muscle. And through all this, the piece of bowel is brought up. So when you have a loss of tissue, structure, and function at the load-bearing muscle. So I brought you here a couple of pictures because it's sometimes very hard to understand what we're talking about. So here is your muscle, here is your fat and skin, here is your ostomy we were looking before, and here are the pieces of bowel who protrude through that muscle layer outside. It's not the same as your ostomy, it's other piece of the bowel. And here is another picture from the different view, right? Again, here is your fat and skin, here is your muscle, abdominal wall, and here's another piece of bowel together with the stoma coming. And we will look at the different type of this. And outside, it's look like a bulge. But not every bulge is a hernia, because you can see here is the fat, and there is no hernia. And those pictures are from Julia Thompson from UK. And here is the pictures of the people who may have or may not have hernia. We cannot assume from looking at it. We need to examine the person. And because of the intra-abdominal pressure, and we will look at what other causes can cause a hernia, the piece of bowel protrude through the layers, and loop of bowel or omentum, which is something which is covering the bowel, going into the beyond the abdominal wall under the skin. So parastomal hernia are more common than we think, and it's a common complication associated with creation of fecal or urinary diversion. And there is a lot of talks and research about which colostomy, ileostomy, or urostomy have more hernias, and I will talk about it. It occurs when a loop of bowel, again, here is a bigger picture, protrudes or push through muscle, abdominal wall, through the gap created to allow the passage of stoma. It wasn't supposed to be a passage of bowel, but it's getting there. This presents as a bulge under the peristomal skin, which may change in size or disappear, because this can get more pressure or less pressure, and depending on it, hernia disappear. This bulge creates uneven abdominal surface, making it more difficult for a stoma appliance to form a tight seal. And this is why you ask questions that you don't have a seal anymore and there is a high frequency of leakage, and what can be done about it. Poor seal increases the risk of leakage and consequently peristomal moisture associated skin damage. So you have damaged skin and the appliance doesn't stick again. Today we're not talking about how to fit appliance over the hernia. And in general, there are different appliances, and I would strongly recommend you to find your MSc who can help you to find what's the best appliance for you. We all have no tricks of trade how to make uneven surfaces to the appliances. And this is very specific question for every individual. So how do we know if it's hernia or not? Again, these slides are from Julia Thompson. So first of all, you need to go to professional who will examine you, asking you to bear and palpating you, putting their fingers on your belly. They will ask a lot of questions about your history and how it's happened and what do you feel and what you don't feel. And while in the medical literature, there is a lot of talks about how to diagnose, CT, X-ray with the contrast can also be used. So if you have a bulge on your abdomen, doesn't mean that you have a hernia. You need to go to professional to find out what do you have. So again, intra-abdominal pressure, this would cause a hernia. And symptomatic parastomal hernias can be as high as 58% when generalized. Sometimes 81% is cited being symptomatic, which means you have some symptoms, and another 25 have no symptoms. And you can see loop ileostomy, loop colostomy, and how many percent cited, and ileostomy, and colostomy. So you can see the end colostomy is the most ostomies with a herniation. This may be an old data, and I've reviewed a lot of articles to find the numbers, and numbers are still inconsistent because there is not a lot of data. There is different samples was taken to check if transverse colostomy is better than ileostomy, ileostomy is better to prevent hernia. And at the end, the conclusion was that there is not a lot of difference, and we need to, which to construct ileostomy or colostomy depend on particular patient and the surgical proficiency. Parastomal hernias most often occur within 2 years of creation of stoma, but possibility of diagnosis continues to 20 years and beyond. Parastomal herniation is also often associated with the stoma-related complication. As we've talked earlier, you can have skin which is leaking and weeping. And a risk of person living with an ostomy, there is pretty high risk to develop a parastomal hernia, but it can vary according to the stoma creation and according to activity and physical condition person have. Parastomal hernia, when you go to the doctor, can be subcutaneous, intrastomal, or interstitial. So let me explain you all these fancy terms. Outside, it can be looking exactly the same. And as we've talked, they can be bulge and no hernia, or the loop will come under the skin in subcutaneous fat layer. Then it will be called subcutaneous hernia. Intrastomal hernia is when the loop is out. You can see it. It's not under the skin. It's fall out from the same hole where is your ostomy, and it's trapped beneath the layers of stoma. This has potential to prolapse because of the too much pressure. And then there is an interstitial hernia, when the loop of bowel of a mental trapped under abdominal layers. So what are the risk factors? Older age, and we will see these risk factors again, and younger age, younger than 15 and older than 70. Abnormal collagen metabolism also can bring to the hernia formation. And here we will talk about maybe supplementation with the collagen can be helpful. There is no research about it, but maybe. When the stoma was created in emergent situation, your risk is higher to develop parastomal hernia. Higher BMI or obesity, if you have a bigger stomach, if you have diabetes, ulcerative colitis, smoking is very big and preventable for the parastomal hernia and prolapse. Chronic pulmonary disease will bring to coughing, and coughing will bring to the increased abdominal pressure. If you have disseminated malignancy, if you have a renal function postoperatively low, if you have a female gender, and there was a question, chronic coughing can be due to the chronic pulmonary disease and smoking, or unrelated. Constipation, again, it's increased intra-abdominal pressure. Hypertension, stoma prolapse, and parastomal hernia in the history. Surgically related factors, colostomy, usually more than ileostomy, and end stoma have it more than loop stoma. Opening, which is bigger, will bring to the more risk to get a hernia or prolapse later on. Stoma location should be inside the muscle and not outside. If there is a longer operation or defect in your fascia with more than 3 centimeters. And when you do reversal of colostomy, there can be parastomal hernia as well. Possible complications. Those are to look for and take care immediately. It can be intermittent obstruction or ineffective irrigation. So when the loop of bowel is cut, and you can see that there is no feces or urine coming out, there is no effluent, it can be obstruction. Skin ulceration and infection seen often because of inappropriate appliance sticking, incarceration, when the piece of bowel which we were seeing stuck there and doesn't get blood supplies, it get incarcerated and then strangulated. And it can bring to perforation of the bowel. Hernia can bring to the back pain and also worsening of the respiratory problem because it affects your diaphragm. And this is just to remind, yes, this piece of bowel, if it's freely moving, then it can be strangulated. But if it's stuck here, then what can happen? Then you don't have blood supplies, or there is a bowel obstruction. Now, people always asking, what's the difference between prolapse and hernia? And it's very hard to understand. But let's remember our anatomy from the beginning. So, in the proper stoma, when it's just created and how it's meant to be, you have your muscle, you have your skin, you have your fat, and there is a piece of bowel who coming. We already learned that with hernia, it's a different piece of bowel which come under the skin. With the prolapse, it's the same piece of bowel which is cut under the skin and then maybe telescoping through. I'll show more pictures so it will be more. And you can have both prolapse and hernia together. So stoma prolapse will come from the same piece of bowel. A parastomal hernia will be a different piece of bowel. So what is prolapse stoma? Usually it's just when intestine become longer than usual through the ostomy site. So it's look bigger than it was when it was created. It's abnormal protrusion of the stoma after creation. So what is the sign of the prolapse? It's sticking out more. It's very simple. It's swelling or changing color to purple, dark red, brown, or black, which is then concerning. Feeling cool to the touch can be concerning as well. Failing to release waste as expected, so you don't have your effluent. And appearance of bulge or lump, like in the hernia. Feeling of pressure, problems peeing or passing the bowel movement through the ostomy. So here is another pictures of the prolapsed ostomy. This is, you can see that your bowel coming through and telescoping inside. You see, so instead of being nice and short here, it's become bigger and falling out. This is a picture which may be less understandable, or for some people who work in the field may be more understandable. So there is a proximal side of the stoma, which is connected here, but there is a gap between abdominal wall and the stoma, and the bowel, redundant bowels starting to get out and get bigger. So how often prolapse happening? So you can see numbers here a little bit lower than with hernia, and it depends on type of the patients or people. So it's between 1.7 to 25% in general. So in children is higher. In patients with colostomy, it's higher than in patients with ileostomy. And if you have a transverse colostomy, it's even higher. Stoma prolapses reported to occur more often in loop stomas and more often in colostomy than ileostomy. What are your risk factors? It's similar risk factors to the hernia. Advanced age, obesity, increase in abdominal pressure. This is the real reason why you have hernia or prolapse. It's increased abdominal pressure. Chronic obstructive lung disease, what does it do? You have a lot of coughing, and then you have an increase in abdominal pressure. Weakness of abdominal fascia, this is something which you can help, and redundant intestine. There are also some risks associated with operation or surgical procedure. Again, when there is too big an opening, when there is excessive space between abdominal wall and stoma, when stoma is outside of that muscle. And this is why it's very important to get marked for the ostomy creation and stoma construction through intra-abdominal road. The absence of fixation of mesenterium to the abdominal wall. Who most at risk for prolapse? Again, the same people, overweight or who gain weight quickly, have weak belly muscles. And remember, a lot of you asked, what can we do to prevent deterioration? Have a larger stomach opening from the surgery. This one you cannot do a lot. And put extra pressure on the belly from coughing, sneezing, constipation, or pregnancy. Can you prevent a prolapse? Absolutely. You can prevent the prolapse by not lifting excessively heavy object or making it with a proper protection. Maintaining a moderate body weight, wearing support vests and belts when appropriate. And this one, when appropriate, you will determine for yourself with your health professional. Eating a balanced diet with plenty of fiber and drinking lots of water to make bowel movements softer to prevent constipation. Practicing good hygiene to help avoid illness that may cause frequent coughing. So, if you already have a colostomy prolapse, a lot of patients come with this big piece of bowel sticking out and they don't know what to do. So how we can, it's called reduce the prolapse. There is a very interesting article and video about from the patient who had the prolapse stoma. You can go and see it. So it's still important to follow all what we've talked about to prevent exacerbation. But if you have your ostomy prolapse, you want to lie back and relax. When you're lying back, what happened? The pressure from the abdominal wall is lessened. And why the prolapse happens? Because of the pressure. So it both can help you with the hernia if it's get painful and with the prolapse. If you have a stoma which is sticking out and very swollen, you can apply sugar. Yes, you can apply a regular sugar. And I had a couple of patients who always took, when the sugars was in the little paper pocket, they always were keeping it with them to sugar their stoma. This will cause fluids in the stoma to be pulled out. And if your stoma is swollen, you can also use a cold compress for up to 5 minutes, but be very careful with the cold not to have a frostbite. When should I contact a medical professional for prolapse stoma? So first of all, when you see your stoma different first time, go and check with your medical professional. But now let's say you're diagnosed with prolapse. Now when it's become purple, blue, dark red, or light pink, or prolapse is cool to touch, looks different than usual, very swollen, and nothing helps, when it's lasts more than an hour and nothing can help you, and when prolapse is painful, all those things, when your ostomy doesn't look like it was before, this is when you want to check with your health professional. This is a baby prolapsed stoma. And actually, this was an emergency, even though it doesn't look that bad, but for the baby, again, it wasn't. So it's very important to know how your stoma looks to have a proper judgment. Something good after we've seen pictures, which was not very pleasant. So what can we do to prevent hernia or exacerbation? So we have modifiable, something which you can do, right? You can check what are you eating and what is your weight. Occupation, not always you can change, but you can be aware and maybe make the decision. Physical activity, it's very important to be physically active. I've seen some questions about I cannot do anything which will engage my abdominal muscle. I was told not to exercise, and actually literature also showing that when doctors say that you cannot do specific exercise, patients prefer not to do any. And when people say you cannot lift, patients prefer not to lift at all. So sometimes we as a health professionals may mislead or tell you things which is not heard by you appropriately. So yes, physical activity is very important, especially if you have a defect in your abdomen. Smoking. So smoking is something which is very important to address. And I know it's not easy, but it's something which can be modified and only you can change it. Now, raised intra-abdominal pressure, so you can deal with constipation and COPD. Make sure that if you're going to have a ostomy or if you already have one, make sure you have your nurse specializing in wound ostomy and continence to be at your disposal, to know where and how to find you. There are some things which we cannot modify: diagnosis, medication, surgical site infection, but we can reduce the risk. And physical activity and abdominal exercises intended to both regulate intra-abdominal pressure and increase tolerance to higher pressure. So just take it step by step and don't expect too much of yourself too soon. Let's say you had surgery a while ago and you were not exercises or you're out of shape. Start slow and safe to increase. What I recommend to all of my patients, regardless if they had an ostomy creation or just had an abdominal surgery, or for the sake, I actually recommend it to everyone, it's a Qigong exercises. I personally practice by Lee Holden because it's free on YouTube, and he is very gentle. I recommend you can just go and Google it. And those exercises are very good for the breathing as well. And we will talk about the breathing. Very important, the way how you stand up from your bed. It's very important that you go on your side, then you push with your hand and your legs. And this is how you sit up in the bed. Now, there are some exercises to avoid. And those examples are from a program which was created by Convatec. And you have access to it. I'll show you a little bit later how to get a hold of those nice booklets which guide you what exercises are safe to do and in what stage. Smoking cessation we've talked about, and it will also help you to prevent cough, right? Weight management, you can go to dietitian or you can just see what are you eating and how you can modify it. Maybe you can reduce sugar consumption or plain carbs consumption and increase berries and proteins and fat. Now, general advice to help minimize the risks of parastomal hernia, which I will return again and again, it's strong abdominal muscles. This will be prevention program, and I will show you research which was done and how it helped people to prevent hernia formation. Obviously, anything, if you're doing something new, you need to check with your surgeon or with your doctor. You want to avoid heavy lifting for 3 months just to let the healing happen. It doesn't mean that you can gradually build your stamina. Good posture at all times, and we will go again and again over those recommendations because they're very simple, very cheap, and very, very effective. Carry exercises below as early as discharge, and use support belt or griddle when undertaking heavy lifting or heavy walking after 3 months and at least 12 months postoperatively. Keep your weight within the body mass index and support your stoma while cupping first few months, because you remember there was an opening there, and in this opening the stoma can protrude, and we will talk about it again. So remember I was talking about Qigong. Intra-abdominal pressure regulation through the diaphragmatic breathing, and diaphragmatic breathing helps you to control intra-abdominal pressure because you are using your upper body and your low and the pelvic floor. So pelvic floor exercises are important, and the diaphragmatic breathing. So during Qigong exercises, you learn how to breathe diaphragmatically. You don't necessarily need to do Qigong. You can just learn your diaphragmatic breathing and start practicing it till it's your way of breathing. And this way you will engage your deep core muscles and will be able to prevent or maintain your hernia. Those exercises, which are very simple, basic exercises that were recommended in the research for rehabilitation, and they recommended as early as day after the surgery with gentle movements and exercises. So you can lie on your back on the firm surface with the knee bent and flat on the bed. Pull your tummy in, tilt your bottom upward slightly, pressing the middle of your back into the bed and hold for 2 seconds. Go slowly. Now, most of you are not post-surgery, so you probably can advance pretty fast and you know your level of exercise. So if some of you are professional athletes, this may be very basic for you. But if some of you were afraid to move because somebody told you cannot exercise, or you were doing everything but not your core, maybe it's safe to start with a simple exercise and then progress. So knee rolling and abdominal sit-ups, but it's not the push-ups or pull-ups. It's very, very low and only to the capacity you have. So people who did this program right after discharge developed, only 15% of them developed the hernia versus people who didn't. And this is the research which was going to follow up for 3 years. And in year 1, there was 28%, in year 2, 14, and year 3, 17. And you can see distribution among ileostomy, colostomy, and urostomy. Urostomy has least hernia, and colostomy has the most hernia. So let's summarize what you can do. Maintain the good posture, stand tall, sit up straight, start gentle exercises, and wear support garments. It's very important to stand straight. Those pictures are taken from one of the Convatec booklets, which I'm going to show you shortly. And it's very important. And go after the session, go to the mirror or ask someone to tell you every time when you not standing straight, because standing straight give you, first of all, diaphragmatic breathing, and second, a proper muscle support. If you feel you're about to cough or sneeze, make sure to engage your abdominal muscles. Do not smoke and avoid inflicting strain. So here is your constipation. So this lady, Sarah, she is a physiotherapist by trade, but she had an ostomy, and she found that there was so little support that she started to develop exercises, and she developed a full exercises for the Convatec company, which they freely distribute as a part of their Me Plus program. And I give it to the patient regardless of what appliance you use, Hollister, Convatec, Coloplast, No Hope, doesn't matter what you use. You can still take this advantage of those exercises. There are some exercises that may be not suitable for you, like plank, full push-ups, traditional sit-ups, double leg lift, pull, feet ball rollout. Those not recommended, but there are plenty of exercises which are recommended, and those are simple ones to start to engage your core muscle. So this is
the Me Plus Recovery Series provides important information on lifting and moving safely, strengthening the pelvic floor, a 3-phase core and abdominal series, and more.
So here is you can again Google your Convatec, call them. They have phase 1, phase 2, phase 3. Find yourself where you are, and you probably can sign up and get all 3 of them. So this is a source of information for your physical activity. Now, nurses specializing in wound, ostomy, and continence Canada also have an education for the patient when there is a teaching booklets for the specific ostomy, as well as some parastomal hernia prevention booklets. You can go on this site also if you have no access to the MScN and you were looking for one, so you can call there, and Troy actually or anyone from the team will help you to locate the closest to you MScN or any resource which can help you to find. Now, most of the companies have some information about the hernia. So this one is from Coloplast. And the next big question, it's about belts. So hernia support belts. They improve pouch adherence sometimes, offer discretion and peace of mind. They reduce bulges sometimes because for some hernia is not as beautiful as I was showing. They sometimes reduce dragging feeling. They definitely definitely help you when you need to have a heavy lifting activity. It helps to control prolapse stoma and help to support any weakened muscles post-surgery. So again, the nurses specializing in wound ostomy and continence have a parastomal hernia prevention big best practice recommendation. Somebody was asking about it. So in their recommendation, they recommend selecting correct garment based on individual assessment. So you would need the help of occupational therapist or your MScN. Cost of the garments are very different. You can use an underwear, supportive underwear, or you can use a belt, and the costs will be different. And the company which making a belt and the material, all in the cost, so you can find out for yourself. Type of the stoma function, with hole or without hole, all can be considered when you choosing what appliance to use. And you can have abdominal binders or hernia support belt with or without the hole. And somebody was asking, do you absolutely need to have a special hernia support? No, there was a lady who is actually retired and not having it anymore. She had an ostomy. She made the belt for herself. You can be creative from one side, but if you're not sure, consult your occupational therapist or MScN or ask your doctor for help. Now, usually in the literature, you will see that the ostomy belt are recommended to wear immediately after the surgery to prevent the hernia for at least 12 months. Now, remember that intra-abdominal pressure will be pushing the bowel, and this is why you're using support belt. But if you have support belt with the hole, it will not stop your hernia. It may give you a comfort because it will put pressure, but it can exacerbate the prolapse. And if the hole have bigger diameter than the stoma, you basically come to the same condition which was contributing to the hernia formation from the beginning. So it's very important to be fitted and speak with a professional. When there is no hole, there is an equal support, and garment should be not so tight so the ostomy can function. So for the type of the ostomy, for example, for ileostomy, you may have a safe garment which has no hole, but some people with colostomy can experience pancaking when they're wearing the hernia belt. You would need to experiment by yourself, but this is what I was explaining about prolapse, which can be contributed by the hernia. It's like a balloon which is popping out. Again, this is Julia Thompson. As this is how she provided an example. If you have a full hernia, then you have forces, which is contradicting. But if you have a hole, then it may be pushed out. So, ostomy support belt versus support underwear clothing. You can choose what's working for you. It still gives you some support. It's your personal condition, how much your own abdominal muscles you have, because what the belts do, they help your muscles, your abdominal muscles. And there is a variety of the belt. And here is an example of the belts with a hole, but there's also belts without the hole. One of the comments and question from the people today was that there is a person in GTA who comes to the home. Here is his website. You can go and see. And this is an example which was provided by him about the hernia. And this hernia is different from the one which we showed you. Another supplier of the belt is a New Hope. And there is a variety of the type of the belts, the widths, the lengths, the holes. They have a very detailed consultation. You can do it with a fitter. You can do it on your own. Again, fitter can help you. Now they have a belt with a lot of different sling-like uplifting support. So this is the belts which, when I've started practicing, this is the one which I was recommending. Those are more expensive. There is also a stout belt, which may be heard, but this belt is not so much for hernia. It's more for the accommodation of the pouch. Now there is a CUR wear belt, and those belts do not need as much custom fitting as the New Hope belts. which may be plus or maybe a minus. It's all very depending on your particular situation. They have no hole with the pocket, or they will have with the hole. They have Velcro. They have different materials and 3 different colors. They also have undergarment, unisex, and it can be enough in your condition and for your support and prevention, or for activity you're doing. So you can do with a fit or without fitter, and you can determine with your MScN, do you need a hole or you don't need a hole. If you don't have an MScN, you can probably determine by yourself as well what's working for you and what's not working for you. If you want to purchase those belts, there is a different options, including online. Now, there was a questions about surgery and advances in the surgery. I did put it aside in case we will have time for it, but surgery and what kind of surgery is good for you is more important to ask your own surgeon in your local environment, because the proficiency of the surgeon, familiarity with the procedure and what fits you is very important. I can show you one of the things of the surgical treatment is applying a mesh. And what's interesting, you will ask me about prevention. So there's some literature right now that mesh is applied during the ostomy creation, and it's also some kind of prevention. However, it's not a standard practice. There is a literature which is saying that mesh can get infected and can be some problem with this. Again, this question, this is actually a picture of repair with the mesh. And there is different type of meshes, and this is all about the surgery, which we are going to cover today. Any questions?
We definitely have quite a few questions here. If we're ready to go through them all. Firstly, I just want to thank everyone who's been asking questions here, and thank you, Rose, for covering quite a few of those. The first what we'll do here is I think we'll try to do this as thematically as possible. But one person was asking about wearing a support belt for at least 12 months. Is there a general timeline that you typically recommend someone using a support belt? Let's assume this person has a parastomal hernia. Is it a certain timeline, or is it based on what you're seeing, the reaction of wearing it?
It's very, very special about the timeline. Let's say you're going to do heavy lifting. Let's say you have right now flu and you're coughing a lot. This is when you want to go back to your belt. You deconditioned for some reason. You can go for your belt. Why you have a belt? You have a belt when your muscles need extra support. So if you know that for some reason your muscles are not enough, then you're wearing your belt. If you know that you're going to do heavy lifting, you're wearing your belt. If you're not sure, speak with your MScN or your surgeon, because everyone is so different. And maybe because if you're wearing your belt, there is no feces coming through. Maybe because you're wearing your belt, there is some weakening of the abdominal muscles. It's all very individual. So theoretically, the belt can be worn. And you can downgrade from the belt to the supportive underwear, and then not. And then you can see how you're progressing with it.
Fantastic. And just on this question as well, and this question comes from another MScN who was asking about if a hernia belt is either too snug or if it's poorly fitted, can this affect output or prevent or even cause, prevent output, affect output, or even cause leaks?
So let's think logically. If something doesn't fit you well, let's say it's your shoe, would it cause the problems? What do you think?
Exactly. Yes.
It will. Yeah. So if something doesn't fit properly on your abdomen, it can cause the problem. It can cause a skin breakdown. It can cause a lot of different things. It can be posture, diaphragm. So things should be fitted properly.
Absolutely. I had a question here. Someone was asking what the website was for the hernia helper. Would you be able to just go back to your slide there for a second? It was from a few slides before, where hernia helper from the gentleman from Toronto. Yes, I'll just put that in the chat.
Absolutely. Maybe I should keep sharing my screen.
If you don't mind, we have a couple questions that might go back to those. Thank you.
Okay.
While you do that, I'll just while you do that, for those who didn't see in the chat already, there were a couple people who were asking for the definition of a loop stoma and comparing that to what a end stoma is. So we've answered that question in the Q&A
Okay,
area.
I will show green window tab here. I'm not use this screen. Share. Use sharing the screen. Here it is. Let's go here. So first of all, the question was about.
It was about the Hernia Helper website.
Yeah.
It was with the photos of the gentleman with the
hernia.
hernia.
Yeah, I remember.
Okay.
Douglas. Okay, here.
That's right, Douglas.
Here.
Yeah. There you go. Oh, it's just herniahelper.ca. I'll put in the chat here. Perfect.
Now, there are other types of belts. The fact that I didn't mention something doesn't mean that it's not a good belt. Again, there was a question, does it need to be this belt or that belt? No, it doesn't need to be anything specific. It should fit you and it should be accessible to you. And if you feel not right in this belt, then it's probably not good for you, even if it's the best one on the market. And if you're in doubt, speak with a specialist. Let them help you out.
Perfect. Thank you.
Lobostomy versus endostomy. So let's find out. Here is a prolapse. So you can see that there is one opening and there is one opening and another opening. So those are loop. There was a loop made and the inside. So here is the picture. So if this bowel was looped out, can you write here?
If you double click on the slide, you might be able to start typing.
No, here. Can we? Yes.
Or
So if this bowel, undo. If this bowel was looped and then the opening was made on the top, then it will be a looped bowel. In this bowel, we have bowel and nothing else connected to it. So this is called the end stoma.
Perfect. And someone mentioned that you might almost see like a double bubble is a good sign of whether it's a loop stoma. You can visually see it sometimes on the outside, like in that photo you were mentioning.
And another thing, maybe you'll have a double bubble because you have a herniation there of the bowel. So again, if you're not sure what you're looking at, go to the specialist.
Perfect. Okay, we'll get back into some of these other questions. I know we've got quite a few coming in here as well. One of the, let me see if I can get better organized here. Some people were asking about whether their hernia could potentially get bigger over time if they're doing even more leisurely activities, like let's say yoga or even walking. Is it typical that a hernia might expand or get bigger if they're not wearing a hernia belt, if they're just wearing a tighter garment, for example, or a tighter underwear?
So back to your question about lobostomy. Sorry, I just Googled it quickly.
Yep, no problem.
Here is your end and here is your loop. I hope this is clear now, right? So here is the same bowel which is coming out. And then there is one from which the poo is coming. This is connected to your mouth and this is connected to your bum usually. And this is just one piece of the bowel. This is end. So the question was about exacerbation of the ostomy.
If can your hernia get worsened or even larger, even if you're not wearing a hernia belt, but if you're wearing tighter garments or tighter underwear, is it still typical that a hernia could get bigger over time, even for leisurely activities like walking or like yoga?
The literature states that some people saying that having a hernia for the people with ostomy, it's almost inevitable event. This is by the fact when people usually do not exercise and do not straighten the abdominal muscle. So when you're doing yoga, next day after the surgery, it can do some bad stuff to you. But when you gradually grow to the exercise regime and you're doing these exercises to even more straighten your muscles, it shouldn't cause a hernia. Remember, hernia caused by intra-abdominal pressure and the opening of the hole. And when you have your muscles and you don't have constipation, coughing, and you don't have intra-abdominal pressure, then it shouldn't get worse. So yes, exercises are safe if you're not sure, because again, it's maybe safe for you, but it's maybe not safe for me because something is there which I don't know. Speak with your doctor or with your nurse and check, is it safe for me? Do I get it wrong? Can I do this exercises? Can I do that exercise?
Fantastic. And so again, I know you mentioned it right there. It's about the intra-abdominal. And so just to confirm, so for some people who had some questions, it would not occur from external trauma or external forces. This is typically coming from the inside, correct?
Yes. Remember this picture? Here, intra-abdominal pressure, and it's pushing the thing out, and it's coming through the hole. So it's not that something putting in. You can get trauma to the ostomy, but it's not usually not a hernia.
Perfect.
Here where
And I think
sneezing,
and
coughing, and here it's coming out.
And I think in one of your tables, you were mentioning some of the risk factors for hernias. I can't remember, it was early on in the presentation. Some people are asking, is scar tissue also, is that typically a sign of a risk factor for a hernia? If you have scar tissue near your
Scar
stoma?
tissue is not written as a risk factor for a hernia, but scar tissue, it's abnormal collagen there. So again, usually when the ostomy is created, scars are avoided, and a lot of time doctors will cut out the scar to prevent formation. But again, somebody was asking, I remember, if I have a scar, does it mean I'll have a hernia? It doesn't mean anything. Nothing is, if you have this, for sure. You even can have diabetes, you can be 90 years old with radiation exposure and disseminated malignancy and still not have a hernia. And you have none of this and have a hernia. It's very individual. To prevent, stop smoking, start exercising even before the surgery as much as you can gradually, and have a healthy diet.
Fantastic. So we have a sort of another theme is talking about a relationship between blockages and a peristomal hernia. Is it typical that if someone's experiencing a blockage, could this be caused by the peristomal hernia? I know we talked about the prolapse as well, where you could see some of that, some of the constriction there.
Same story here. In the prolapse and in the hernia, you can have intermittent obstruction, which is blockage, or ineffective irrigation, which is blockage again. And blockage is a sign you need to go, right? If you don't have it released, you need to go and see practitioner. Even if you don't have a hernia, what we say, if you have cramps which are not relieved by warm water and the abdominal massage, you're going to see, because there can be peritonitis, there can be perforated bowels, there can be a lot of things which need to be checked. Till you learn to find your signs and symptoms of the blocked abdomen and perforation, you go to professionals to check it. With experience, you will know, oh, it's like with the kids. Initially, we all run to the doctor, and then kid can have even 40 degrees, but you know, okay, it's just a flu. So the same story. If you're in doubt, better go and check. And a lot of companies offer support, nurses on the phone, and other stuff. And if you have your own M.Sc nurse, you probably have a number to text and say, hey, I have this and this and this. What's going on?
And on that note too, I know I'm just seeing if we get to some more questions in the next few minutes here. We have a different theme as well, and this is talking a little bit more about the stoma itself and some specific questions about identifying if it is a prolapse or not. Some people are asking, at what point do I recognize that it could prolapse? Is it natural for my stoma to extend by even an inch or so, or even a couple centimeters over time? Will it naturally sort of extend away? And on top of that as well, is it natural for my stoma to change color?
What is prolapse is when your ostomy is bigger than it was. Is it dangerous? Most of the time it's not dangerous. Can it prolapse more? If there was a reason for the prolapse and you didn't remove this reason, it can. Some definition, it's 6 to 7 centimeters. Usually they don't repair. I had a patient who had literally this big bowel out, and it wasn't repaired. Usually repair of the prolapse is happening when there is a dangerous situation, dangerous condition, when it's something which is unevitable. If it's not fixed, then it will bring more troubles or quality of life.
Right. And speaking in the opposite direction, do you find that it's normal if the diameter of the stoma increases naturally over time, or is that a sign of
Again, there is
something more?
nothing normal. You can gain weight, you can lose weight, and all this. Is it normal when you were fitting a 10 size clothes and now you're only fitting 15 or 16? It's life, so it can change. If something is abnormal, you will feel pain. And if you are not sure, speak with your specialist, speak with your doctor. Usually, initially, stoma is swollen, and 3 to 6 weeks after the surgery, it's getting to its size. But even when you're fitting your belts, there was a note that you need to refit them because your abdomen, usually we gain weight, we lose weight, and it's need to be refitted to make sure that it's working well.
Fantastic. And I know we're getting closer to our time. One of the questions we had at the end was talking about concave appliances and how do concave appliances factor into choosing products for outward bulges and for hernias? Is this something you could comment on?
Exactly. So this is what I didn't speak about appliances here, but in general, you can go to the website of the company, and the only company who have concave appliances right now, it's a Coloplast. And they have an amazing, beautiful, detailed guide how to fit an appliance and what's working for you. And they have it for patients, not for nurses. So it's very easy to understand. You can also give them a call and then they can guide you. It's always easier if you will have your MSc nurse. And again, Troy, you can attest that we can try and help people to find them in all different pieces of Canada. And I know somewhere they are abundant and somewhere they're very rare, but we still can link them. And there is we can help them through the video calls, but individually it's very important. So usually with a prolapse stoma, you don't want to have convex appliance because it can push more and damage the loop, and you want to cut bigger. But your personal case should be looked at, and this is why I didn't go into this in particular, because for some, usually with prolapse, depending on how long it is, you need a longer bag. You may have a flexible bag versus rigid bag. However, I had a patient for whom I was using concave appliance and convex ring when he had a prolapse. It's very dependent on the curvature of the abdomen. And before you go and buy full box, call the company and ask you to send a sample, because sometimes I think, oh, concave will make whole difference for the person, and then person put it and absolutely hates it. And sometimes I think maybe yes, maybe not, and the people love it. So always try before you buy.
Thank you.
Because it's a lot of money. I know it's very costly appliances, and this is why it's better when you have your MSc who can give you a sample.
And what we'll do here too, and I know we have quite a few questions that are left over. Some of the questions are asking, will we be able to share the presentation and some of the links? What we'll be doing, and we have our Yasser and our team behind the scenes here. When we send our post webinar email, we'll also send you the link to where you can find the recording today so you can review some of these notes. We'll see if we can include some of those links in that post webinar email as well, for a briefing summary to Yasser and our team. So we will make sure to get those links to you. For those that we haven't been able to get a question to, do send us an email.
Yes, you can wear a belt with diagnosed parastomal hernia. If you have 9 blockages, make sure to see your surgeon and ask him about, do you need do you have a problem or you don't have a problem, and what do you need to do. 9 blockages is a lot. Now about mesh and all this stuff, speak with your surgeon. And the mesh which was in 1994, it's totally different from the mesh which is 2025.
Thank you. And I know that we have some of those there. what we'll do is, again, send us an email here. We have
and
our
I
info
really
email.
want to answer core
Yeah,
focused
sorry, please go
workout.
ahead. Yeah.
If you do it, if you're doing it with your person who knows your condition and they can guide you. You remember I showed the exercises which actually aimed at the core. Walking is a core focused exercise. When you just walk, it's a core. Swimming, it's a core focused exercise. It needs to be gradually improved. So yes, definitely. But you need to do it under supervision and you need to do it gradually. But it's very, very important. And you can start with breathing. You can start with slow moving of Tai Chi, Qigong. You can do yoga, but again, not the downsized dog, upsized dog right away. Make sure you do gradually.
And what we'll do too is, I know you mentioned in your presentation, there are some resources. We have a full guide for whether it's a ileoconduit, ileostomy, colostomy. There are teaching guides that show by steps and good exercises post surgery that you can gradually start doing, as you mentioned there. Rose will share that, and I know Rose, you shared some great videos where they do that demonstration through Convitec too. So we'll make sure that gets to you as well. Most of this information, if you need to get more resources, we have it on our Ostomy Canada website. The www.nswoc.ca website has some of that as well. But again, we'll follow up with some more information for you there.
Were you talking about this one, right?
Yeah,
nswoc.ca,
exactly
patient education.
Yes, and we put that in our published area of the Q&A. You can click on the link there, but we'll follow up an email with the specific link to make it easier for you to access. They're very easy to follow as well, and it should be more specific for you. Before we get off here, Rose, are there any other final comments you wanted to make? Any topics that you think are worth addressing here before we head off?
Thank you everyone for coming. This is number one. Number two, please take out from this presentation that you can make a difference in your own life. Start exercising, watch your diet, and stop smoking. And if you do 3 of those already, then maybe invest in yourself and go to professional to help you to upgrade your level.
Thank you so much. And Rose, you've been such a great help with Ostomy Canada and with M.Sc throughout the year. So we really appreciate you sharing your expertise today. For everyone else who's on the line, as I said, we do these webinars 4 times a year. One will be coming up in April. So do stay tuned for our an email from us launching that, both the date and the topic for that one. You'll be getting an email from us afterward. Please fill out that survey so we can know what topics most interest you in the future. We're going to do our best as possible with the resources we have to answer your questions and get you connected with the people that can help you most. So on behalf of Ostomy Canada Society, our team is here. Thank you so much for coming online today, and we hope you have a good rest of the day. Thanks, everyone.
Thank you, everyone.